In this lecture, we're going to focus on something called the knowledge to action cycle. And the knowledge to action cycle is a flowchart or a paradigm that presents a pathway on how to engage in knowledge translation from the beginning to the end user. And what we see here are two basic elements of the knowledge to action cycle. On the outer part, with the curved arrows, indicates the action cycle, while the interior triangle represents what we'll refer to as a funnel, where the knowledge that is created at the very top of the funnel will eventually become more specific and more refined, that can eventually form products, tools, and something that can be used by the healthcare practitioner or other practitioners. And we're going to, although this is a cycle that in theory can start at many different places, for our purposes here in this lecture, we're going to start at the very bottom here in the identification of a problem. And that problem might be a clinical case. It might be a problem associated or a question associated with training athletes or developing a rehabilitation protocol. And so although the entire cycle, as indicated a few seconds ago, begins with the generation of new knowledge, we're going to begin at the very bottom here from the practitioner or the user's perspective. And so the user must have a reason to access that knowledge, and that reason is based upon the identification of some type of problem by that practitioner. And so once that problem has been identified in the knowledge to action cycle that we begin here at the bottom, reviewing and selecting specific areas of knowledge, and those are the research articles that was mentioned earlier in a previous video, takes place here, and then the practitioner or the user would adapt that knowledge to the local context. And one other important consideration is to assess the barriers to putting that knowledge into action. And so what we're going to focus on in this lecture and in subsequent lectures are these three critical components of the knowledge to action cycle. On this slide, what we're looking at here is the funnel, and illustrated on the outside of that funnel is the action cycle without the additional details that we saw on slide number 17. Now the funnel here, as indicated just a few moments ago, begins theoretically with the creation of new knowledge, but that new knowledge that is created through research does start to narrow until it gets to a very specific product or tool. But to get to this point in the funnel, the end users, the practitioners, must have identified a reason to access that knowledge. And so in doing so, the ability to translate that knowledge in a manner that is usable will eventually get to the bottom of this depiction of the process with this funnel. And this funnel, or in this process, in this schematic, was generated in this widely referenced research study in 2006 in terms of how to actually carry out knowledge translation. And so in an application, as an example of how we could possibly or apply the knowledge to action cycle, we're going to look at the example of inspiratory muscle training, or IMT, in people afflicted with COPD. And this is chronic obstructive pulmonary disease, and there are many treatments for people afflicted with this particular type of lung disease. But inspiratory muscle training is just one of the possible treatments for people with this condition. And so, in terms of understanding this from the knowledge to action cycle, by beginning with the identification of the problem that needs addressing. Now, refer back to slides 17 and 18. This would be the tip of the triangle at the bottom. Just outside that triangle in the action cycle where the practitioner would identify the problem. And the problem here is determining if this type of treatment, having patients go through muscle training specific to the muscles that will pull air into their lungs, are those protocols helpful? And that would be one sort of problem that would be identified. But if it is found to be helpful, and many years of research and clinical practice have found it to be helpful, the second problem that might arise is that's highly effective, but it might be underutilized to a significant amount. And so either one or both of these two items could be a problem identified by the end user or the practitioner. Identifying and reviewing select knowledge relevant to the problem is referring to the body of knowledge through publications and other types of communication media to demonstrate the value of inspiratory muscle training. Now, once that's been identified, adapting it to the local context becomes critically important. And what we refer to in terms of the local context, we're referring to adapting what has been demonstrated in research studies, original studies, as well as secondary sources of information to health professionals that actually lead the rehabilitation programs. And so we're looking at respiratory therapists, nurses, physical therapists, and physicians. Now, adapting this to the policymakers, administrators within healthcare facilities and hospitals within which these rehabilitation programs operate would not necessarily be the primary end user, but would also be captured in the end user for that local context, because the decisions made by the administrators could divert resources to those programs that have a strong evidence-based level of effectiveness. And in doing so, assessing the barriers to apply that knowledge and identifying those barriers would be critically important, because it might sound great to put these programs into play, but do the end users know how to use it? Now, in the case of respiratory therapists, nurses, physical therapists, and physicians, through their own education and training, they do receive the instructions on how to apply inspiratory muscle training. But is it accessible? Is there unique equipment that must be used for patients to do this inside the clinic or inside the hospital? Is there a sufficient amount of allocated time for the healthcare professionals to apply this to the patients with COPD? And so what we see here is that although we step through the identification of the evidence that would suggest that inspiratory muscle training is important and coming up with a way to use it, identifying the barriers will allow the end users to do something about the barriers and surmount those barriers to using those to be able to put it into practice. Coming back to the central part, the middle triangle, if you will, of the knowledge to action cycle paradigm, by focusing on that funnel, the funnel represents the process of knowledge creation. Keeping in mind that the actual cycle that includes awareness of and dealing with barriers exists outside of that funnel. But the funnel itself involves activities and processes that are related to the application of that knowledge, as well as the cycle. So we ask the question, where does the knowledge come from? Well, knowledge primarily comes from empirically derived research studies, and these are studies that generate information through direct observations. But it's important to note that studies that take a analytical or theoretical approach are also considered to be of high value in accessing that knowledge. In terms of the progression through the funnel, once again here when we talk about the funnel, we're referring to knowledge creation. As we progress from the top of the funnel down to the very bottom narrowed part, the knowledge becomes more refined and is packaged up in a way and expressed in a way and communicated in a way that's useful to the stakeholders. And this begins with step one, which is referred to as knowledge inquiry. And the important component of knowledge inquiry includes what are called the primary or the original studies. These are the research experiments conducted in order to generate information through direct observation that did not exist before the study was carried out. And so the original study as published will publish the results of one experiment. Now, when we take a look at these different studies, these studies do vary considerably in terms of quality. Some studies are of higher quality than others, and some studies carry greater relevance than others, and that has to be identified particularly with the original studies that generate what we often consider first generation knowledge. Now, these studies are not refined for the stakeholder or the end user. And the stakeholder and the end users encompass a large group of individuals that include the healthcare practitioners and the patients. And so these are studies that are published and expressed and communicated in a very clear way specific to the purpose of carrying out that experiment, and not necessarily in keeping in mind the potential for usage directly by practitioners. The second step here is referred to as knowledge synthesis, and this moves to what's called second generation knowledge. And the second generation knowledge involves the collection or the aggregation of existing knowledge. So the first generation knowledge that we just acknowledged on slide 21, the new information conveyed through original research studies, are collected at the next generation after those studies have been published. Now, the process of synthesizing that first generation knowledge into second generation should be reproducible and not haphazard in any sort of way. And so this involves the identification of those original research studies, appraising those studies for quality and relevancy, and then organizing them and synthesizing those original studies in a way that can be communicated in a relevant way. And a relevant way of doing that is prior to the identification, appraisal, and synthesizing of those studies is to do so from a position of asking a specific clinically oriented question. And this second generation knowledge takes the form of systematic reviews and meta-analyses as described earlier in this unit. And so when we talk about the systematic review or the meta-analysis, it's a very systematic, reproducible way of collecting information from those primary studies and expressing it specific to a question that would qualify those studies for entry into these two types of literature reviews. The third step is oftentimes the very challenging step of expressing the second generation knowledge into third generation knowledge, which is to develop a series of what the step 3 title here is, tools and products. And so this refers to the development of practice guidelines for practitioners, perhaps even for patients, decision aids, and rules that would not necessarily require the end user to go back and to read in depth the first generation original studies. And so the purpose at step 3, the purpose of the third generation knowledge, is to present the collection of all that information from steps 1 and 2 in a very clear, a very concise, a very user-friendly format. Very explicit recommendations should be provided here at this point without necessarily providing the justification that would require going back to the original studies. So at the third generation level here, we have a set of recommendations and tools and aids given due consideration to the fact that the background knowledge has already been confirmed. And the intention here overall at the third step is to influence those individuals that have a stake in this research and a stake in the operation of some organization, is to influence the behavior. And that behavior refers to clinical practices and patient or client or athlete outcomes. One such example of the knowledge to action cycle is implemented by the Dietitians of Canada, which is a professional organization that regulated or that licensed dietitians in Canada can use to put into practice the most current and cutting edge science that is relevant to nutritional practice in the country. And so the practice-based evidence in nutrition, which is a registered trademark, not a trademark, but a registered term here, PEN, provides a series of benefits, not for patients necessarily, but for dietitians to use and as part of their practice and apply to patients. So we won't go through the intricate details of the PEN system here, but what we're seeing here is a very user-friendly system developed by the Dietitians of Canada for use of their members to put into their clinical practice. So this ends this lecture on an introduction to the knowledge to action cycle.